becoming intermittent, and we're going back to using thallium occasionally, although it's inferior from an imaging standpoint in a few different methods, in a few different ways. At any rate, whatever the tracer is, you inject that IV, and then you obtain images of the heart, and then either the same day or later in the same day or on a different day, you inject the material or scan the patient during a load, and you cause load on the cardiac system by either exercise or drugs. And then you kind of compare those two, and what you're looking at is either fixed defects, which means there's an infarct that's occurred and completed and the myocardium scarred, or reversible defects that show up during exercise but reperfuse during stress, and those are areas that are at risk for infarction. So that's the cardiac perfusion study. And again, we'll look at an example of that later. Cardiac MR, well, despite years of intensive development and a lot of investigation, MR seems to be one of these things that's going to be development in the future rather than present. Right now it's used in research purposes and with ongoing developments it may find more use. It's usually used for people that can't have IV contrast in larger centers. The technique continues to evolve. It is possible that cardiac MR may one day provide a single modality that can look at the coronary arteries, cardiac valves, and myocardium in one exam. Right now, it's not really something that's going to be routinely ordered by primary care providers. Echocardiography, that's in use, of course, widely all over the place, but as a radiologist, I don't, at this point in my career, did once, but at this point in my career, don't interpret many echocardiograms or any echocardiograms, and that's because of the ongoing turf battles between cardiology and radiology. Cardiologists have tried to or successfully taken over the imaging of the heart in most places, including echocardiography. Echocardiography is good for evaluation of cardiac valves, looking at morphology, stenosis, and insufficiency. It's good for looking at the pericardium. It's good for looking at chamber size and wall motion. It obtains some information about heart and great vessel pressures, and it's the exam of choice for looking at acute valve insufficiency, such as somebody with heart pain or chest pain may have. And it's good for looking at patients with chest pain and a new murmur. These patients may have acute valve insufficiency, and that's critical to know. Since it's generally performed by cardiologists, I'm not going to speak a lot further about echocardiography. So, those are sort of your general tests available. So the next point is that everyone with chest pain who needs imaging basically gets an X-ray. Sometimes it's the only study you need. Now, how worthwhile is it getting the chest X-ray? Well, actually, frankly, a lot of times it doesn't really show you too much. Imaging of chest pain always starts with a plain film, but it doesn't often really reveal anything helpful or diagnostic. An investigator named Templeton found that about 23% of plain films obtained on patients with chest pain in the emergency room had an abnormality that influenced therapy. That's probably generous in my own experience, but he found 23%. The likelihood of finding a significant abnormality in a patient undergoing evaluation in an outpatient clinic is probably going to be even less than that, because those are ER patients. If you look at the table in this slide, you got 300 patients presenting to clinic, and this will show you why most of the plain films are going to be unremarkable, where you look at those causes of chest pain and they're not going to show much on a chest x-ray. However, I'm going to now review a few of your cases where you actually do see something on a chest x-ray as a cause of chest pain. And some of these patients came through the ER, probably most of them. There's a 52-year-old man with chest pain, and clearly here the arrows show he's got an acute onset of a pneumothorax. And of course this is one of the things that pretty much everybody can recognize and should recognize as a cause of acute chest pain and dyspnea, shortness of breath. This fellow had it recognized pretty quickly and got a chest tube in this film, and this picture shows him before and after placement of the chest tube, and you can see his lung has reinflated nicely. Usually these pneumothoraces are secondary to a bleb or a little kind of a little air balloon or pocket that's connected to the bronchial tree that's on the surface of the lung, rupturing, and then air collects in the negative pressure of the pleural space. They're typically self-healing. I mean, you don't have to go in there and put a stitch in them or anything. You put the chest tube in, the body heals it up. But during the time when that lung is down, people can be extremely uncomfortable and have a lot of chest pain because they're really kind of suffocating. Here's a 20-year-old man with chest pain, PA chest exam, very subtle abnormality on this exam, which I'll show you a blow-up of in a second. On the lateral study here, slide 49, of the same fellow, you see again a subtle abnormality. I'm not going to reveal what that is, but here's a blow-up of his cardiac shadow and of his anterior mediastinum on the lateral study. Everybody made up their mind as to what they think might be going on. The arrows point to small abnormal collections of air along the mediastinum here, and because of the suspicion of a pneumomediastinum, the patient was sent for CT. Now, a CT scan here, filmed with lung windows, shows a small amount of air right there along his aorta on slide 53. Slide 54, without arrows, and slide 55 here with arrows, shows you air along the esophagus. And finally, slide 56 and 57 with the arrows shows you air along the anterior aspect of the heart, causing the abnormality on his lateral chest x-ray, and some air there along his esophagus posteriorly. So this young man had a spontaneous pneumomediastinum. Pneumomediastinum can occur with or without a pneumothorax, and generally it's a cause of chest pain that can be diagnosed on a chest x-ray. Like pneumothorax, it's more easily seen on a CT scan. Here's an 86-year-old with some persistent chest pain following trauma. His chest x-ray didn't look too bad. There's his frontal study. Here's an oblique view of the ribs. Hard to see much going on there. Blow-up oblique view of the ribs. You're on slide 62, slide 63. If you look real hard, here's the arrows that show you that rib fracture. And then here's a two-view, one of his chest x-ray and one of the rib fracture. Now, rib fractures, how important are they to diagnose? It is good to have a diagnosis in many cases, especially if you're dealing with someone with chest pain. But rib fractures can be all but impossible to see on the chest x-ray because of the technique they're taken with. However, you'll see the significant complications of the rib fracture, such as the hemothorax and the pneumothorax, which are actually more important to know about than the rib fracture per se, typically, clinically. If someone is point tender along a rib and has had trauma to that rib, the rib's probably fractured. Whether we can see that or document it on an x-ray or not is probably neither here nor there. The important thing is, do they have a pneumothorax? Do they need a chest tube? The other issue is that frequently ribs will fracture at the costochondral junction, and those will just flat be invisible pretty much on a CT, even a CT or x-ray or whatever you want to do to try to find those things. So basically, rib fracture is more important to know that they've got a pneumothorax or hemothorax than it is that they have a rib fracture. But it is, it's always good to make a diagnosis. Okay, 70-year-old woman with chest pain, a chest x-ray. You'll note that on this frontal chest x-ray, her breast shadows are asymmetric. She did not have a mastectomy, but she does come in with chest pain. Her lateral study looks a little fishy, if you know what you're looking for, what you're looking at. And on the frontal and lateral study, I think the thing that you can best appreciate is the fact that her bone texture is abnormal. The thoracic vertebral bodies are not really the right color. They're mottled and too dense. Her ribs, you could probably say the same thing about. Here's a chest CT that was obtained, and you'll notice how distorted the tissue is on her left side along the pectoralis muscle there. Again, she did not have a mastectomy. Here on image 71, we see a great deal of abnormal texture in her vertebra. There are areas of basically sclerosis here with this arrow, another arrow, for two arrows showing additional sclerosis, more sclerosis back here. I mean, everywhere you point to in this vertebra, there's abnormal texture. And there's some areas of lucency. It's hard to tell whether that's normal bone or whether that's abnormally moth-eaten bone from tumor. Here on slide 77, you see a coronal reconstruction over CT data, and you can figure out in a hurry why all acquired lateral and chest x-ray looks so abnormal. Here are arrows along all the abnormalities in her thoracic spine. On a sagittal reconstruction, sort of mimicking the lateral chest x-ray, you see a bunch of sclerotic lesions in the sternum and throughout the spine. Just set of arrows, which I got a little carried away with. Here's a composite of all 4 pictures. The chest x-ray showing the retracted breast shadow from a large primary breast cancer. The 2-view chest and reconstruction CT showing diffuse metastatic blastic bony deposit in this patient with chest pain and diffuse metastatic deposit. So the chest x-ray did show the cause of the chest pain in this patient. And occasionally you'll have patients that come with metastatic disease as the cause of their pain, and you'll see that on the chest x-ray. Here's a 47-year-old man with chest pain that came in, and he obviously has a large lesion there in the left chest. On the lateral study, and the lateral study with arrows, you see that large round area of opacity in the posterior chest. He did get a CT scan. Here you can see a combination of consolidation and ground glass opacity. Radiologists use the word consolidation, meaning on a CT scan, lung density that obscures the lung markings and vessels. And then they use the term ground glass opacity for increased density that is greater than normal lung tissue but less than consolidation, and which in general does not obscure the native lung markings. Here are 2 arrows showing that area of combined consolidation and atelectasis. And here's the same fellow with the chest CT on slide 89, filmed at soft tissue rather than chest windows, and you can see that the ground glass opacity sort of goes away. The effusion fluid along the oblique fissure and posteriorly stands out more on this picture. The arrow here is on a mildly enlarged hilar lymph node, not infrequently seen in most patients with this condition. Here's a sagittal reconstruction of the chest CT showing you what you're seeing on the chest x-ray, large area of consolidation, ground glass opacity, here marked by the arrows. And finally, here are 4 different pictures showing the chest x-ray, PA and lateral view, axial CT, sagittal CT, sort of correlating those findings. So this is pneumonia causing chest pain in a 47-year-old man. This is a so-called round pneumonia, which can mimic a mass. A follow-up chest x-ray after treatment demonstrated complete clearing of this pneumonia. So these are some of the other